This recording is protected by copyright. No part may be reproduced without the prior permission of the University of South Australia.
So now we have Penelope Lee talking about the use of personal narratives in understanding art and communicating the artist experience. She studied visual arts, fine arts sculpture honours in the early 1990s, and Penelope's had multiple solo exhibitions, participated in over 42 group exhibitions, both nationally and internationally, and completed 2 major public art commissions. Penelope has worked at the Dax Centre since 2004 and is currently Manager of Professional Development and Public Programs. Over the years, her work has traversed research, education, special acquisitions, co-curating, film documentaries and the Ethics Committee. In 2012, she commenced working part-time at in Education and Outreach at the Centre for the History of Emotions. Welcome.
Can everybody hear me? No, really, it sounds so loud. You're right, it sounds like we're yelling. Can you hear me at this level? This is up. I feel like I'm swallowing it, but I will try. Thank you so much for giving me the opportunity to talk to you today about some of the work that we undertake at the Dax Centre. While I'm speaking, I will be showing you a repertoire of creative works that we hold within the collection, and I'll be pausing on some of them for you to have a closer look. But before I can tell you about our current practices at the Dax Centre, I really do need to speak briefly about its history and how that history has in fact had significant impact on how we do things today. So for those uninitiated to the Dax Centre, we're a centre in Melbourne, in Victoria. We're based at the University of Melbourne, though we are not part of the university. We're a standalone organisation. And we promote mental health and well-being through art and creativity. The Dax Centre incorporates what is known as the Cunningham Dax Collection, and that is a collection of over 15,000 creative works made by people with an experience of mental illness and or psychological trauma. There's only 3 collections of this kind and scale in the world, one being in Lausanne, the other Prinzhorn, and this one in Melbourne, which is the largest of its kind in the Southern Hemisphere. And it was founded by this particular man, Dr. Eric Cunningham Dax, who was an English psychiatrist who came to Victoria after there was a review about the care and treatment of people with mental illness in the 1950s, and he headed up what was then known as the Mental Health Hygiene Authority. Probably the equivalent would be DHS today. Dr. Dax made some significant achievements in his time within this role, but what is relevant here today is that he introduced arts therapy into psychiatric hospitals within Victoria from the 1950s until their closure in the early 1990s. And this was a very visionary thing to do. There had long been an understanding that people with mental illness were creative and spontaneous works were being made in institutions across America and Europe and England. However, there had been no formalisation of it. And it was through Dr. Dax seeing the work being done with TB patients in England where art was being introduced as sort of an occupational thing, that he recognised the secondary gains for the individual, how these works and making these works ameliorated their anxiety or their boredom and gave them a capacity to share their particular narrative. So he introduced arts therapist into the services that we have within our mental health system, and it was to complement the other forms of treatment, whether it be talking therapy or whether it be some other form of psychological therapy, medication, psychosurgery, all the other things that were pretty prevalent back then in the 1950s. The idea was that people were encouraged to attend these particular arts therapies, and this is a picture of one of the sessions that happened, not in Victoria. This is actually one that happened in Netherlands, but it was an identical model that we had here in Melbourne, where people were encouraged to put marks and gestures on paper that best described their lived experience of mental illness. And this would help shape, I suppose, diagnosis, treatment and prognosis. They were encouraged to put words on paper, but in a visual language, and to tell their story spontaneously and unmediated. So there were no prompts, there was no still lives put there, there was no exchange of how to produce a particular image or use a particular material. It was found that by doing so, that the people that participated not just offered a window into their psyche or their inner world, but also for the treating team, that is, but also that these works would offer them insights into how they were progressing. And they were very potent tools. They were often done in single sessions, so they weren't works that were worked on over long periods of time. The next couple of 10 works I will show you are from these sessions. Now you'll notice that it all has name of artist withheld. In many of the cases of the works that we hold, we are aware of who the creator is, but because these works are protected by the Health Records Act, the highest bar of confidentiality is that we cannot disclose any information about the creators without their consent. And as was early spoken about in the previous paper, that idea of seeking consent is something that has shifted quite significantly in the early parts of the DAC's history compared to what it is today. These people are unknown to us. We have 8,000 of these works. These works were acquired by Dr. Dax at a time when the hospitals were closing down and they were being turfed into large bins and being thrown away. So of the thousands and thousands, he was able to retrieve 8,000 of these works. However, we have, of the 8,000, only 1,020 indicators of whose work they were and what diagnosis they had. Dr. Dax would refer to these as X-rays of the mind. As you can see, this particular, and I can take my time, as you said today, so I might elaborate since we've got a bit more time, but this particular work was made by a gentleman who often, when he experienced psychosis, he would have what was called a thought insertion. So he thought messages were being transported into his mind, so if he started to create hats, it was an indication that, one, he wasn't travelling as well, but two, that he was developing a device which was enabling of him to live a reasonably good life, because he was able to ward off these thoughts being inserted into his mind by these rather creative hats. Now these programs continued up until a period called deinstitutionalisation, which was in the early 1990s. And so the way we treated these works in the past have had to be readdressed in the current day. Dr. Dax recognised that while his clinical team learnt an enormous amount about that individual's lived experience, that they weren't just a cluster of signs and symptoms that they read in medical books, but this particular person who had an experience of mania may have been rather florid at the time of the making, and so that would be talked about and fleshed out and help in assisting him to recovery. Now, Dr. Dax felt if the clinicians gained these understandings about the individual experience, that the general public equally would do also. And one of the things he was such a significant champion of was this idea that one of the more disabling effects of mental illness is the disability associated with it. So even when people left hospitals, the stigma associated with mental illness, the lack of understanding by the broader community, meant that that person continued to live a rather difficult and disabling life. And so he was all for educating the wider community about that lived experience. And he felt if he did so, that in a sense would enable a reduction in this stigma to happen. Sorry, some of these pictures have lines across them. That doesn't come up on the Macs that I produced this on, so apologies. These lines are not part of the artwork, or they've just only appeared. So Dr. Dax, as I said, acquired these works and then set about starting to exhibit them. And when he exhibited them, he initially did it in a hospital setting, but then that shifted to a gallery setting. And what was very evident, when that shift happened, if you take something and strip it back and put it in a room that's painted white and it's a cube, it looks and resembles an art gallery. And with that comes certain expectation by audiences. And as audiences have continued to come to the Dax, there has been this tension about what it is that they're looking at and what they're trying to understand of that work with little collateral information. What was only offered to them when Dr. Dax used to curate the exhibitions was his interpretation of the works. Now that's fine, and there's no criticism of that. However, it was a particular person's perspective, and it wasn't the creator's perspective, and it wasn't the creator's voice that was at the forefront. It was Dr. Dax as a clinical psychiatrist whose lens shaped the way he saw these particular works. So why these works were well recognised for their ability to work as collateral information when you're acquiring information about an individual, when they're in an inpatient facility, they're not exclusive in that, they're multidimensional. Many people would not see these works as clinical records. A lot of people would see them as art, purely as art. Other people would see them as a cultural record or an historical document which would tell of a time when people were in hospital for enduring periods of time, when they didn't own the intellectual property nor the physical property. Now, a lot of those, again, those things have changed. And it was these things that we had to start readdressing at the Dax Centre. It's fascinating, but it's not important. Graham Doyle is one of our artists, and I can show his name because he's one of our living artists that we have dealings with, and he works with neologisms, and neologisms is a term in psychiatry where you make up new words. I don't know if any of you listen to people on the radio, Red Simons does it, where you try and legitimise a word by creating a meaning for it. He is fantastic, and in fact, as he said, often he would be viewed as becoming unwell when he used neologisms, where for him, because as a poet and a writer and an artist, he in fact was more creative when he was well, and it was in fact an indicator of when he was travelling well, not when he wasn't travelling well. So that's where art is not always a direct diagnostic tool in that respect. So Dr. Dax continued to juggle this phenomena of the idea of wanting to educate the broader community about the experience of mental illness, but at the same time not wanting to cause any harm to the individuals whose works he was drawing upon to do this. So that balance of do no harm, but for the greater good. And so how he did exhibit them, as I said, was without any information about the particular artist, without the voice of the artist. And his argument for that too was that it was a means of protecting the individual. It was at that level of confidentiality was the only way he could do it. And he also seemed to strongly believe that perhaps the person who created the work wasn't the best person to speak about the work. Now, I know that plagues most artists, that often we're not the best people to talk about our particular work, but still, the fact that there was no forum in which to do this was quite significant. And the belief that you couldn't do it was quite significant. So if we fast track to today, I work in a very, very different climate. I've had the luxury of actually having worked with Dr. Dax. He died at 99 3/4 only a few years ago. And it was really interesting to be part of a wave of change there, and moving out of that particular modality of working. So with this very, very modest beginning, because Dr. Dax never intentionally set out to create a collection of work. He acquired this, he salvaged it. Technically, the work was legally called abandoned, so he could preserve this work. But we never, and we still to this day, don't see ourselves as owners of this work. But from those very modest beginnings, the last few years have just been this really, really laborious process, and an engaging one and a thorough one, of looking at this collection and looking at the ethics behind it and the moral and the legal issues surrounding it, to make sure that we are a collection of its time. So while we do acknowledge that these earlier works tell of a historical time, they need to be dealt with significantly different. And also we have, as mentioned by an earlier speaker, Nicole, the idea that we're in a climate of human rights, and people with experience of mental illness equally have rights that should be acknowledged. And so this whole custodial and paternalistic approach of the past had to be changed. These next few works are works that indicate some of our new trajectory, and we're moving into this area of trauma. The reason being, and I don't know if many of you are familiar, but one of the diagnostic bibles of Western psychiatry is called the DSM, and we've just gone through a new one, and they pretty much list and define what is the mental illnesses of its day. So in 76, homosexuality was a mental illness. Obviously that isn't the case today, but you know, Asperger's is sitting within a spectrum of an experience that could sit in there. There's other sort of things that are appearing all the time. So trauma has well been recognised as being a shift in someone's mental health and well-being. And so this is the work that we are more proactively, rather than just acquiring by attrition, we're proactively seeking out. So this is by a child who was part of the affected by the Sri Lankan tsunami, 2005. This is a body of work by an adult survivor of the Holocaust, and in 2007 myself and a curator spent around 200 hours working with adult, child and children survivors of the Holocaust, collecting work which was in existence. They didn't make it for our purpose, but it was work that many of them had made as a consequence of their experience, some 50 years after the event. Not just were they traumatised by the Holocaust, but by moving to Australia and having to raise a family. So often many of them didn't actually come to making work until much later. And in Melbourne we have one of the third largest community of Polish Jews from the Holocaust. So it's quite a significant number. This, Rena Hoffman, is a child of a survivor. And the exhibition that subsequently grew out of this collection looked at transgenerational trauma. Some of the success of the Dax in recent years has been in acquiring new works, is been because of our building trust with our communities that we work with. We take up to 3 years to acquire work. And we do this in a very sensitive way, because when the work becomes part of the collection, it's that idea of it being a very clear and informed consent by the individual who donates that work. We want to make sure that they are aware that if they become part of the community within the collection, that it is not just the artwork that we're interested in recent times. We're also interested in the narrative in and around the work. And okay, this particular work, and I suppose I don't want to give you a warning, but this body of work is one of 200 works that was acquired by people who experienced childhood abuse. And as adults, they entered arts therapy. Arts therapy is being, I suppose, acknowledged as being a frontier in which children survivors are enabling to visit their trauma, name it, identify it, and hopefully start a pathway of recovery. Because that trauma has often happened in a period where language has not been formed, they draw very heavily on the visual. But it's very connected with their story. This particular body of work, though, we have additional caveat on this work where we don't, as staff, present this work without the statement of the individuals who made the work. Why? They don't want to be visible. They want the issues to be visible, and they want their stories to be visible. And another thing that we do here that I was just mentioning earlier, when we come across content which is sensitive and people do want to share their story, the way we move around that is provide a capacity to do what's called a thick disguise. And that means that we can shed back some of the specifics but keep the authentic story still there. So a 27-year-old fellow from Frankston becomes a young male from the eastern suburbs, something like that. So we have to decode at least 3 of 5 points of identification so people don't get to know who the individual is. So this one says, for as long as I can remember, I had always imagined that I had a memory storage system within me. I had described it as the tricky, ticky-tacky boxes and would commonly draw boxes when doodling. My box system is an elaborate room filled with floor-to-ceiling cupboards. Each cupboard held a memory in isolation. Some cupboards held memories that were connected to other cupboards. Often they held things like striped pyjamas or children's books. Some were images connected to events like birthdays or places like the swimming pool. All of them were too valuable for a child to let go of. I specifically didn't show any explicit work by that collection because without, in fairness to people here, it was not the right forum into introducing that. But building up very clear ethical frameworks in which to operate at the DAC Centre has fostered a very trusting relationship with new artists today. And this is particularly evident in the fact that when we exhibit the work, people, when they donate it, have an opportunity to tell us what this work is to them. If it is more art therapy or if it is something that they want to share but don't want to disclose who they are, anything is permissible. If it is something that they want to be right there in the forefront, their story, their work, their narrative, then that is also facilitated by us. What's been interesting for the staff, and I should comment, the staff are a very diverse staff. I also have a mental health background and a health background, and so I probably reflect some of the demographics of the staff, where we have psychiatrists, psychoanalysts, social workers, occupational therapists, we have museology, art history, and curators working at the DAC. So we have this diverse community of people. We're all very part-time, and we do it for the love of it, really, because we get very little funding. We're a part-time organisation, and we achieve quite a lot just on working collectively. So this is a project I'm currently involved in, which is to do with the 2009 Victorian bushfires. So as much as just our exhibitions have expanded as a consequence of the collections that we're currently acquiring, our educational and our exhibition programs are also expanding, and we have capacities now to create resources and also have a really dynamic public program which invites artists to speak. They're always invited to do so, and as clinicians we work very closely with them to support that opportunity, because it can be enormously empowering for an individual to get up and speak about their story. We do a lot of prep for that. It can take weeks. It can take weeks and then it doesn't happen. It can take time. It can happen spontaneously, and then there's the aftermath, often once they've made a story public, and how they process it then. But today I want to particularly talk about the work of one artist, because if you ever have the opportunity to come to the DACs, what is really interesting is there's a particular aura, I think, when you walk into the centre and you see the works, and you find yourself asking, who is that person behind that work? What is their lived experience, and what were they trying to communicate? So I should just go back. When we acquire work, it's done, as I said, we can identify particular groups, but we don't approach any artists directly. That creates a dynamic where people may feel somewhat, privileged in being identified, but also sets up a power play. So what we do is we work with the communities who tend to work with the communities that we've identified, and just offer the opportunity for people to self-select and identify and come forward if they want to make a donation. What we have steered away to from now is families who want to make donations on behalf of deceased family members who had an experience of mental illness. Again, we can do that, but we're very thoughtful and, I suppose, again, thorough in trying to get an understanding of that person's history, but not just through the lens of the family. We are very composite of the idea of doing posthumous harm to an individual, so they, in a sense, may not have wanted their personal lives to become in a public domain. So again, we're constantly juggling these tensions, and sometimes, and we don't know whether we will look back in 50 years and think we did things well, or whether we still have gaps. In many senses, we're a work in progress. But an artist who really does, I think, throw up those questions of who is this person behind this work is this particular woman called Rosa Nearon. I came across Rosa, excuse me, in 2010, and I was working on another project, the Holocaust project, as she has a Holocaust past. And she she's been very, very significant in us doing quite a cosmic shift at the DACs, where it's been the first time we've collected a body of work by a person who has experienced a physical illness which has shaped her mental health. So recognising, I suppose, illness in that. I didn't set out to acquire this work or work specifically with Rosa, but a relationship formed over about 12 months, and it became very evident that she was curious about the DACs because she herself had been producing work about her experience. Now, Rosa's experience is that she has a life-threatening illness, and it has been incredibly confronting to her. So over the year, we got to know each other, and then she pretty much dumped this idea that she wanted this body of work and we were going to be the repository for it, and this is where she was going to tell her story. And why we don't shirk from showing difficult exhibitions at the DAC Centre, the harsh reality is that Western society often relegates the topic of physical illness and the contemplation of our own mortality to the margins, as it does evoke very, very strong emotions. So people would come to the DACs pretty much informed that, okay, I'm going to be seeing some challenging work around the experience of mental illness, to now be coming in to seeing work that might actually confront them and question their own mortality was not something we had been well practiced in. Also working with Rosa, it was a number of came to mind in that her precarious health was evident and still is evident over the time frame that we've worked with. And there's been many times where we literally thought she may have been sadly taking her last breath, but she has, like Lazarus, come back again. So working under those duress, that sort of duress, was very impactful. Also selecting what we wanted rather than what Rosa wanted us to have. There was a balance that we had to come. Also, beyond Rosa is the needs of her family. She has extended family, of some of which live overseas, and they, rightly so, did not want Rosa just shedding all her worldly belongings, which is not inconsistent with someone who's coming to a stage in their life where they are reviewing all these things. And while she generously wanted us to have hundreds and hundreds of her works, her family were also complicit of the fact that they in fact may want this work once Rosa passes away. So there was that thing. And then it was about thinking of our institutional responsibilities to the audiences. So with Rosa's story, she was first diagnosed in 2000 with breast cancer, but it was a further diagnosis in 2012 with bone metastases after a secondary breast cancer that made her not just review her life, but also then started to have this profound psychological effect on her. So when I met up with her, she was already chronicling her body and her bodily and physical emotions, as well as her diagnosis and treatment, and that existential questioning of life, as you can possibly see in this work. So in terms of staff, we had to skill up. We are obviously comfortable in that domain of mental illness, but not around the idea of death. So it was important for us to recognise that a diagnosis of advanced disease is frequently more devastating than an original diagnosis to an individual, and that can often be precipitant to further emotional turmoil and existentialist despair. Rosa spoke about death anxiety a lot. Now, death anxiety has been written about by the American psychiatrist Yalom, and he talks about that death anxiety needs to come out. It needs to become an entity. It's one of those physiological things that you have in the pit of your stomach, or it might come into your dreams and such. But the effect is that you need to exorcise and rid yourself of it. And obviously, creativity is one of the most profound forms of language for people in this situation. If, in fact, they may have had other marks-making techniques, whether it was writing or music, they may, in fact, pursue that. But the whole idea of creativity is quite a significant thing towards people's when they're trying to process this death anxiety. It has been written about a lot for nearly 3 decades in this domain of psycho-oncology, first noted by the psychiatrist Jimmy Holland in The Human Side of Cancer. Also the idea of pain has been written about by the cultural theorist Scary, who's spoken a lot about that pain often resists the power of verbal or written language, and as a consequence you cannot do justice to it. And so someone like Rosa found that she had to paint it. That was the only way, and she says this: I use painting to describe the feelings I have no words for. When they appear before me, I can see them and I can conquer them. So this was not just cathartic, this became a healing tool for Rosa, her making her works. Now, she was not prompted to make these, she just made them. Rosa has a background of, I suppose, painting, in a sense that she was an architect, a businesswoman, an illustrator and an author. She's a force to be reckoned with, and she is a prolific painter now. She has got better with her materials, and so you see a really significant improvement over time. From the beginning of working, beginning of working with her, I negotiated with Rosa to also include her support team because of her precarious health. And so we worked with Dr. Di Clifton, who is head of psycho-oncology at St Vincent's, who is both a great support of Rosa and also at times a therapist for the family. This open consent was sacrosanct, but it was also negotiated between all of us that we could draw on each other at times, because at different times we all found this very confronting to acquire Rosa's story. And Di Clifton was extraordinary. As with all our processes, we start when we acquire work by doing a oral history in a sense, and that's done with 3 to 4 people, unlike what was mentioned by Karen George when you do an interview and there's 2 people. We often invite people to bring a supportive other. We don't do them on Fridays. We don't like to leave people up in the air and over the weekend having to perhaps ruminate about what they've said publicly or out loud. We're also very mindful that we are reigniting trauma. We're opening up wounds, and it is imperative that we can navigate that or follow that up following the event. At all times, people have total control over the environment. We sometimes tape them, or if they're not comfortable with that, we have a scribe. But the arrangement is that we always have a clinician doing it with the curator, so it's a combination. And they are prompts. We're not expecting, especially for our purposes at the DAX, the whole story to come out, but we are wanting what is relevant to our understanding of this particular work. And when this work is as visceral as this, it's important to get it right. So that's where I think the mental health background has been a very useful tool to know and be able to know when to continue something, but also to know when to stop something. We approach this process doing a bit of a hybrid, I suppose, about informed consent. We use a little bit of the Mental Health Act, which is all, has a lot around informed consent, to make sure that at the time of interview that people are composite of their faculties, that they're aware of what they're entering into. So that does make a big difference. And we, even with this hybrid, we make sure that that it still covers us legally too, and as it does, covers Rosa legally. What's really important is, even though I was really familiar with Rosa's story, was that I wanted, I suppose, to examine the questions that she had not posed herself in her body of work that she had done to date. And she had accompanied these paintings first with her own script. So I was wanting to examine that just a little bit more. But what resulted was such rich material that that she found so satisfying in sharing, that she in fact suggested, and I suppose with Di, and it had been talked about a little bit, but the idea of participating in a film, and at the end I'll show you some of this film. And she did that because she likes to communicate. She wants to communicate. She thinks there is such a tyranny of silence around dealing with impending death that it needs to be spoken about. So even in doing the film, though, there were significant ethical issues to consider, because I was very conscious of not wanting to put our self-interest, so that is the DAX, wouldn't it be great to get this on film, but to put that ahead of her needs and making sure that at no time were we exploiting that trust that we had. So it had to be carefully calibrated, really. So despite it being quite a struggle at times, it led to wonderful, I think, revelations. Rosa identified that obviously in her making all these works before I even met her, that she got something out of making them, but they, a bit like this Buddhist notion that she talked about, often in the making of them, they then had no purpose. So we were giving them a second life. and that she found totally invigorating. So I think what ended up being, and we did have an exhibition earlier this year of her work, was that her work ended up being not, as you would have expected, just an exhibition that looked at this concept of memento mori, which is looking, I suppose, around the concept of death. It came much more of an exploration of living with illness, but facing one's mortality. And it had enormous impact on the public. Some of them felt that they should have had warnings before they came into the exhibition. They were so confronted by it. But generally, most people found that touching on this topic was a taboo that had long been overly neglected. And as I said, it wasn't just about the artworks, it was also about the narrative and the words that she wrote. I just want to finish on these last two works. This is by her partner, who did 2 collaborations with Rosa. And it was this idea of recognising pain beyond those experienced just by the person who has the illness. And he was very much saying that portraits are very autobiographical also. And he wanted to reveal his feelings for Rosa as she wanted to reveal, and this is Rosa, her feelings for him. And so they faced it very bravely together. So in a nutshell, I'll finish up now. It was a really, wasn't an easy project, but I would do it again anytime. I think what's very clear to me is how temporal this particular exhibition and this particular story is, because if we did it today, 6 months later, her story, in a broader sense, would have been the same, but her memories and her recollections perhaps would shift a little bit. It was very profound to work with her, but also the family. And in the end, about 6,000 people saw this exhibition. And we had lectures, we had Rosa present, we had symposiums, we had the huge thing, as well as the film. So I don't know if we've got a few minutes to show, 5 minutes or 3 minutes of the film.
Sensations come back. I was totally reborn. I was ecstatic. I was wandering around as happy as I've ever been.
If you've got time, if you want to. Is that right? So you just tell me when you've had enough. How long does it go?
I was in venture capital. I was your classic female executive flying around, working hard, powerful job, very externally focused, a lot of presentation in Australia and America. I was really the external corporate exec, and I stopped work and was instantly diagnosed with breast cancer, and it was a blessed relief almost, because I had an excuse to stop. For the first 6 months of the treatment, the chemotherapy and the radiotherapy, I started to think about things that weren't business, that weren't, are we going to reach targets? What's that presentation going to be like? And I found these wonderful things inside me. I started off by painting flowers because it was like spring for me. I suddenly came to life in a completely different way. I had never stopped and just sat there and thought about something. It was funny, I had felt like I had been numb for years, and suddenly I could feel my hands, I could feel my feet, I could breathe, and every time I drew these flowers, I felt like I was flowering. It was just like people used to say to me, "Oh, I'm really sorry about you having cancer," and I go, "This is the most fabulous thing that's ever happened to me. It is really a rebirth." And when you're very sick with your first chemo, everything stops. You can't eat, you can't drink, you can't swallow, you can't poo, you can't do anything. And as your sensations come back, I was totally reborn. I was ecstatic. I was wandering around as happy as I've ever been. I really didn't get into starting really painting. I mean, all that pretty illustration and scenes and snow and beach, that's just nonsense. and being trained as an architect, I can draw. There's no question about that. But the second time I got cancer, and the severity of it pulled me up, and I thought, cut the shit out of your life, Rosa. Do what's important. You don't need pretty flowers and beaches and stuff like that. Say something that's real. Do it for yourself, because no one's going to like it. No one's going to be interested in how bad you feel or how constipated you are or how scary it is. But if you draw it and you paint it out there, you can look at it. You can understand it, and you don't have to load somebody else up with it. I didn't want to go around to my girlfriends or to Mike and keep saying, oh, I feel terrible, I'm going to die, death's really scary. If I paint that and I look at it, I can size it, I can understand it, I can go into the corners of it. I would find myself waking up 2, 3 in the morning, and I don't want to lie there, and I know, it's like I'd got to get rid of a load, and I'd run downstairs and I'd start painting fear of death, or how sick I felt, and I would just go for hours, you know. It wasn't thought, I didn't think about the colour, I didn't think about sketching. I would just put it out there, and it'd be board after board, canvas after canvas, and I'd look at it, and I can't believe that I'd done it, but I needed to. And then I felt very peaceful, because it wasn't me any longer, it was me on the canvas, which was a different person. And the size of the fear could be any size, you know. I would paint how fearful I was of death. I would paint my pain, because I was very painful. I had the bone cancer, and it's very painful. There's no word to describe it. It's toothache in your legs. But it wasn't part of me any longer. It was there, and I could step back from it, and I could be myself, and I could be a person. I didn't have to load anyone else. And I just bypassed the whole whinging and moaning and groaning part of my life. And it was... I'd start to laugh at 5 o'clock in the morning, be myself, and I'd want to eat and do things. I felt very joyous, because it was over. It wasn't me, and I didn't have to mull on it.